Now it is my privilege to invite Dr. Hadley Wilson, which we always call, as I said in the morning, always call it the ACC Presidential Address. So, Dr. Hadley Wilson is going to be anointed as the president in March next year in New Orleans. And he has had exceptional training. He's an interventional cardiologist, did his medical school at Duke, followed by his internal medicine residency, chief fellow at Vanderbilt, then the faculty there, and then joined the University of North Carolina. And there he's now the clinical professor of cardiology, also the director of the cath lab and executive vice chair of the Singer Heart and Vascular Institute. So he's going to be speaking about facing the inevitable, addressing the international crisis, and physician burnout. So, Dr. Wilson, please. Thank you.
Okay. Thank you, Dr. Narula. Most kind introduction, and many thanks to Dr. Sharma, Dr. Kinney, and all of you for having ACC here. And it's quite a pleasure that we're able to come here every year at one of the top innovation centers, not only in New York, but in the country and the world. And I did do or call in this sports period of football and soccer in the fall, I called an audible and thought maybe you would be more interested, although I will talk briefly about burnout, about the cardiovascular future and the new frontiers as your ACC sees it. And I have no disclosures.
I'm sorry.
No worry. Yes, no, my fault that I didn't communicate with you. So again, as I said, this is a great topic to be talking about now, and I can't think of a better place than in this innovation center, and I can't think of a better time to be talking about this, as we know that medicine and cardiovascular medicine is somewhat under assault with many obstacles, many threats to how we practice for our patients and for our members. And one of the ones that I think we're all familiar with is that there is a shortfall in our workforce. And as you can see here, various projections over the next decade are that there will be a shortage of cardiologists in this country from as little as 4,000 to as many as 7,000 by 2030. And we also know that there is this so-called gray tsunami of now nearly 30% of cardiologists in this country are over the age of 60. We're not alone. Our frontline workers, probably more important than us. There looks to be a shortfall of about 500,000 RNs by the end of this decade. We also know that by survey, about 21% of nurses coming out of the pandemic say they no longer want to be in patient care areas, and they would prefer to find other ways to use their skills. And even right now, currently, there's a 10% shortage of RNs nationally. And put on top of that, the stress and the burnout that we had with the pandemic, which really was going on beforehand, but was really exacerbated, and maybe a spotlight was shown on it. I was part of the ACC Clinician Wellbeing Survey that took place in the height of the pandemic with over 2,000 cardiovascular professionals worldwide that responded. And as you can see, just going across the board, looking at those pre-COVID in gold versus those at the peak of COVID, really around the end of fall of 2020, early 2021, you can see a near doubling in all categories of burnout, including all cardiovascular professionals, US cardiologists, even international cardiologists, fellows in training, and a whopping 164% increase in burnout among our cardiovascular team members, our frontline workers. So what have we been doing about all this? Well, maybe not a lot over the last 60 years. As you can see at this typical photograph of a patient waiting room in 1962 on the left, and compare it to earlier this year, and really looking at this, you would say not a lot has changed, except maybe that it's more full in the waiting room now, and it's more full of senior members. And of course, we cannot skip the impact of COVID-19. And as we know, it was a catalyst for telehealth, and we've learned a lot of lessons from that, which hopefully we can carry forth to our best advantage. And as you see at the peak of the pandemic in 2020 and 2021, there was as many as 70 to 90% of all of our visits were through telemedicine. And now this year it's dropped anywhere from 0 to 30%. But again, we learned a lot from this, and we need to carry those lessons forward. So this has really brought us to a perfect storm, as Zeke Emanuel has said in his book, of a catalyzing crisis of care transformation. If we just go around this multicolored bubble, as I pointed out, there's a workforce crisis of MDs and frontline workers. We also know that the Medicare Trust Fund is projected to become insolvent or bankrupt in 2026. As we go over to the innovation side and the digital world, we lack interoperability, and we need digital health tools if we're hoping to progress in the new age. And then again, as I mentioned, COVID-19 is a huge disruptor. And now for the past 2 years, there is a declining life expectancy in the US after 100 years of improvement, successive improvement. Now for the past 2 years, our lifespan is predicted to decline in the US. And then on top of that, although we had an excellent talk on value-based care earlier this morning, we know that those types of systems have not gained wide acceptance, and there is still a siloed delivery system, and we are having difficulty with this catching on to try and give us value at reduced costs. But something that we know that is a constant is change. And this is from Eric Astroteller. He is the chief science officer for Google X on their so-called moonshot. And he described several years ago to Thomas Friedman that really for centuries, technology has lagged behind human adaptability until we had the onset of the industrial age. And really, I think the crossing of the lines here represents the start of this millennium, 2000, where now technology is rapidly advancing faster than normal human adaptability to keep up with it. So we need to learn faster and govern smarter and take this as an opportunity rather than falling behind. And one of the best ways that I would propose to you that we can do that is through our transformation of care. And we need to do this through our digital tools, including monitoring, remote patient monitoring, AI, as was discussed also earlier today, telehealth. We need to keep those rules and lessons and use that to our advantage moving forward. And we need to expand our care team, not only to the physician, but all of our caregivers in a shared decision-making, shared care approach. So we know about monitoring. We have those for personal use. More than 80% of North Americans have a smartphone. And we also know that millions have Fitbits and Garmins and other personal use devices for their own wellness and risk assessment. But also in the cardiovascular realm, we know that we have rhythm monitors that we order daily, and those are really information that can be pushed to the healthcare provider, And then we also know that there are implantables like pacemakers, ICDs, and the cardiomems, which I'll discuss a little bit in a minute. And that information can be pulled from the patient really synchronously or asynchronously, really with, throughout without their consent, so that they can be continuously monitored. And then, of course, we have the evolution of devices. We're pretty familiar, again, with wearables, and I'll discuss those a little bit as well, and the implantable devices. But there's some new devices available, ingestible devices. There is an elastic patch that can be put over the carotid and measure blood pressure continuously, and now even smart contact lenses that can measure serum glucose online. But with these, there's also issues. So they're mobile devices and digital health, and some have said, let's shorten that to a mobile health age. And IDASIM has given a great review of this several years ago in New England Journal, talking about the sensors that are available and our digital biomarkers and trying to integrate those with our electronic health record. But with all that, we know that there are challenges. There's challenges of the regulation and certification of these devices, their validation and accuracy, as well as the compliance and patient acceptance, and the privacy and security and worry about hacking into these devices, as we sometimes hear on occasion reports. And then also the question of the equity of access. Actually, although these devices initially can have some cost, we also know that socioeconomically, lower income groups are not disadvantaged in terms of having smartphones. They have the same percentage of smartphones as higher economic groups. So really just getting these devices to them, we compare that and use that to try and achieve some equity of access and healthcare. So let's just talk a moment about AI. This is, I think, a great example from Norton Health Kentucky Pilot. That's essentially a suburb of Louisville. And they have an AI-facilitated acute stroke care system of care, which is definitely the top 10 in the country for stroke system of care. And it starts out with a team, well-educated paramedic EMT team that has a BFAST protocol to look at the patient at the site, at the home, and determine whether or not they have focality that suggests they may be having an ongoing stroke. That team then, by smartphone, can communicate and go directly to the nearest CT scanner 24/7 and have a non-contrasted head CT scan done. And again, neuroradiologist does not have to be present, and it's read by AI. And if it determines that there is a high likelihood of stroke, then the next step is contrasted CT angio and location of the possible stroke site. And if that appears to be the diagnosis from AI, then that sets off this system of care that actually has the transfer of that patient then to a tertiary quaternary center, where there is a smart CT interventional suite available for that patient to then receive whatever is needed to bring about thrombectomy or open the artery. And all of this is then followed along the way by smartphone. And through this pilot, they've reduced their door to thrombectomy time from 119 minutes to 90 minutes, which is one of the best in the country. And we also had a great talk about cardiac CTA and AI. And this is from my friend Andrew Choi down at GW. And he published this last year online in JCCT, looking at coronary CTA read by 3 level 3 readers, and then also by consensus, and compared that with that read by AI and over 200 cases, and showed that the AI-read CTAs also were more efficient. They took less time, usually about an average of 10 minutes. They were reduced costs, and their accuracy was actually better than the consensus of the 3 level 3 readers. So what about wearables? I think we're all very familiar with the Apple Heart Study, which is probably the biggest study that came out at ACC prior to the pandemic in 2019. And there were over 400,000 voluntary Apple Watch owners that participated. It was sightless. It was by their consent. And then if they detected an arrhythmia on their Apple Watch, then they could have a monitor sent to them for a period of 2 weeks. And then there was a low incidence, but very specific in the less than 1% range of detecting about AFib in about 30% of those patients who initially thought they might have an arrhythmia. So it was a high positive predictive value for this study, and unique also that it was sightless. I think another very interesting trial, much smaller, but also just intriguing about the combination of wearables, was the alcohol and atrial fibrillation study by Marcus. And they had 100 patients with known paroxysmal atrial fibrillation in the previous 4 weeks. And they then had dual monitors, the Zeo patch, and this unique transdermal sleeve on their ankle that could detect continuous alcohol monitoring. And then the patients were surveyed as to how many drinks they had in a succeeding 4-hour period. And they were able to actually show that there was a correlation of risk, 1 drink, 2 times odds of developing AFib in the succeeding 4 hours, and more than 2 drinks 4 times, and so forth. So very interesting combination of wearables to look at increasing risk of that. And then probably one of the areas that's had the most study for wearables, of course, is our patients with heart failure. And Moabali and Kittleson had a great review of all of the different wearables and remotes that have been used to track and hopefully direct, guideline-directed medical therapy for our heart failure patients, including these standard biometrics, and then also looking at lung congestion through thoracic impedance through permanent pacemakers and ICDs that were already implanted, or a dielectric sensing patch on the chest. And then also the CardioMEMS, which I'll discuss just on the next slide, as well as a inserted invasive left atrial permanent pressure monitor. But the bottom line was that with all of these devices, they were able to perhaps have guideline-directed medical therapy to improve their symptoms, but didn't have any reduction in overall outcomes. Champion trial, we all remember from a decade ago, and the bottom line on that was that using the pulmonary artery implanted sensor, they were able to, on the red lines here, to show reduced hospitalizations over the next couple of years, as well as reduced combined endpoint of mortality and heart failure occurrence as well, although actually overall there was no mortality benefit, but there was a 36% reduction in hospital-related heart failure hospitalizations. How about some other more unique wearables? One is the Bio button from BioIntelliSense, and that's a continuous vital sign measurement that's small, attached to the patient. It's coordinated or linked to their smartwatch. They also can complete a daily health screener survey, and then all that can go up into the BioCloud, where there's applied advanced analytics to really depict or detect or suggest what the patient should do thereafter for that day. And then it comes down from that app whether or not they're cleared or not cleared for the day to go to work or to school, or perhaps seek higher medical care. So that's a unique device that we're exploring. And then just to go through some more novel ones that you may or may not be aware of. One is the face-to-gene, which is, in this case, looking at facial expression, and then that's compared with a catalog of over 250 genetic abnormalities linked with congenital heart disease and others, and they have some correlation, and they're continuing to explore that possibility. There's also a voice recognition biomarker that, according to certain tonality, high-pitched tones and so forth, that they've identified that have up to a 3 times more incidence of acute coronary syndrome moving forward, or even 3 times more incidence of residual plaque in those patients. And then another one that I mentioned earlier, the ingestible pill, and it's FDA approved for Abilify, which I think you may be familiar is a medicine for schizophrenia and also bipolar and even depression. And it can be linked to the patient's smartphone as well as to their provider, and it can guarantee in some of these high-risk patients whether or not they've taken their pill daily. So that was just sort of a quick spin around, and this is actually through the ACC Innovation Group, which is led by Dr. Ami Bhatt. Some of the programs that we are now involved with, mostly on a consultative basis, giving some gravitas to these organizations, but all of them are part of our mission to transform cardiovascular care and improve heart health. And I want to assure you that your dues do not affect this in any way. This is, if there's any, and it's minimal support, it's mostly consultative to these companies. It's less than 5% of our investment portfolio. So just going around the clock, Heartbeat and Clilexa are two companies that basically are a virtual first treatment for cardiovascular patients, particularly in remote areas like in Wyoming or out west, where the patient can have, continuing, as we experienced in the pandemic, they can continue long-term relationship with their cardiologist and know whether or not wearables or other monitoring devices can be sent to them, and that information done remotely without the patient having to travel long distances for an office visit. And then down here at 8 o'clock is the BioIntelligence, which is the bio button that I described. Butterfly is a point of care ultrasound, and I know that Dr. Narula knows a lot more about this or that technology than I do, but we are continuing to evaluate that. Clearly is another CT angio company like HeartFlow that has a project to look at plaque characteristics as well to try and potentially predict acute coronary syndromes in the future. Going around at 8 o'clock, CARTA have a lot of hope for this. We have several beta sites around the country, which is a NLP, natural language processing program that essentially scans electronic health record and extracts data for the NCDR, eliminating the need for these data input clerks. And so, could be potentially, as was pointed out earlier, the manpower or woman power is the biggest expense to healthcare. If we can also causes burnout too, if we can have a program that will fill our registries without having to input it, manually, that would be a great advancement. Evidation is over 5 million Americans have been part of this, which is basically a database platform for all of your health records and also your wearables that can be controlled by the patient, and then they can volunteer to be in a study like Apple Watch or what have you, but it's all completely according to their risk and their consent. And then Heart Hero is a handheld defibrillator, which I think is just amazing, and I think we'll see that having rapid adoption. And Dispatch out of Austin, Texas is essentially an urgent care van that goes to the site and hopefully can treat the patients in the home without them having to go to the emergency department, even the office, or to be hospitalized potentially unnecessarily if they can be treated in the home and keep that care local. And likewise, we're trying to co-develop frameworks that guide clinicians in this tech adoption. ACC has been part of a telehealth workbook or guide for patients with clinical issues for telehealth management of heart failure, ASCVD, atrial fibrillation, and several others. And also through the Consumer Technology Association, we've published a best practices for consumer cardiovascular solutions, and with the World Heart Federation, a roadmap for digital health in cardiology. So again, just to drill down on a few that we've spent more time with, one is the ZEO patch, which is arrhythmia detection from a single lead ECG, and it's been shown, at least 30% or more superior to Holter or event monitoring, and it's from a database of nearly 100,000 ECG records that have essentially drilled down to 10 arrhythmia classes and has expert level accuracy greater than 93% for detecting arrhythmias. And then here's several of the programs, again, that ACC Innovation Program is watching or is involved with, including photoplasmography, which you could consider Apple Watch 2.0 or 3.0, which not only is detecting arrhythmias, but of course oxygen saturation, and in some cases also able to detect blood pressure as well. Now here are some others that ACC's involved with. One is this one out of Sweden, Acarix, which is an ultrasound applied to the chest and actually is sensitive enough to detect coronary flow and predict coronary stenosis in those who have chest pain or shortness of breath prior to having this evaluation. And then here, of course, point of care ultrasound linked with earbuds to give you a phonocardiogram. Koala here is another single lead ECG event monitor that can be linked to the smartphone. Smart socks that have heat sensors in the socks, in the fiber, that can detect a rise in temperature that might suggest, the early onset of diabetic foot ulcer in those with neuropathy. And I think one of the most interesting is this infrasonic hemodynographic technology, which is basically taking specialized earphones and going the other way, listening to the patient, listening to their pulse, and they've had the highest detection of valvular abnormalities from that, as well as arrhythmias and potentially even heart failure as this is being further tested. So what are we going to do with all this data? I mean, you can be overwhelmed. You can have data saturation as this senior appears to be having right here. And so there are some tools to help us with that. One is the complete e-diary, as you can see, and it can actually handle up to 7 different inputs of biodata, and along with that can actually have a program for the patient and suggest that they, for example, get their oxygen saturation reading or take their medication or maybe give a urine or blood sample at the office. So it can have that sort of wraparound total care for the patient, as well as these other programs that are all in that space of platforms for comprehensive home monitoring. And as you can see, there's just a number of these, almost 10. We've been most involved with Maya over the last 5 years, one of the first at the innovation program. And I was part of the innovation development work group for a few years, and so saw this come along. And actually, I think one of the more unique things about it is that the doctor and the patient can describe or prescribe what they may need sent to them, again, remotely. And Maya will actually give them an individualized patient kit of whatever type of remote monitoring they may need, as well as instruction and contact to follow up. So you've seen this pyramid a little bit earlier this morning, and I would submit to you that a digital health strategy personalizes population health, and for chronic management, probably one of the largest areas it can help us with is burgeoning of elderly patients, is it allows patients to partner in their care while remaining local and perhaps not overtaxing our systems, particularly our emergency departments and our hospitals unnecessarily. But then it also can help us with detecting rising risk, and if so, identify potential progression and address that promptly, hopefully even remotely by change in their guideline-directed medical therapy, or sending them additional monitoring devices, or potentially even scheduling an office visit. And then at the highest level, as they become potentially acute, it can require intervention and orient patients to the right next test, clinical team, and location of care, as I showed you in that Norton, Kentucky AI-driven stroke program. So again, for the future, I think we're going to need to rely on a digital health strategy to stem the rising burden of disease that we see, keep CV care in the community and in the home as much as possible so that we're not outstripping our resources. We need to have interoperability and increase our electronic health record value, optimize our clinical workflows. Hopefully that will make us more sustainable and optimize our resource utilization. So again, I would say the transformative potential of digital health strategy will be the new cardiovascular landscape that we need if we expect to move forward in the future with asynchronous communication, patient remote monitoring, electronic consultation, a blending of in-person and virtual synchronous visits, clinical remote monitoring with high-grade medical devices. We need digital tracking and wearables, and we need further analyses and employ data and artificial intelligence. So the future is now, and we need to embrace it. Thank you all very much.